So welcome to today's webinar resident series, Fundamentals of Removables, Analog and Digital Processes and Materials. It is a webinar being presented by Tremaine Watkins, CDT. He is our Clinical Director of Guided Surgery Implant Solutions.
Glad to be with everybody. Thanks for taking some time this morning. So here we go. So I got my couple housekeeping slides as well. A lot of housekeeping here today. I am a full-time employee of National Dentex Corporation, but there's no other financial support for this presentation. So let's talk about removables. So if you look at statistics on this, it's interesting to see the range. I think most people think about the American College of Prosthodontists. Sorry, I'm at an airport today. American College of Prosthodontists numbers that say that there's 120 million people missing at least one teeth. I've seen a National Institute of Health study that said that 52% of people, majority of people, are missing at least one tooth. Again, American College of Prosthodontists, 12 million edentulous people in one arch, 23 million fully edentulous. Now, I think most of us would say that today, endosseous root form implants are the best way to treat missing teeth. And we have predictable methods for augmenting hard and soft tissue. And so today, most people who are missing teeth could get an implant. So why are we even talking about removables? I think one of the things to keep in mind is that not all of our patients are going to be willing or able to do implant therapy. And oftentimes tooth loss is not, as you know, even across demographics, but it's oftentimes focused in groups that have less economic means. And so you're going to see removable patients in your practice. Statistically, just dividing the number of patients who need therapy and removable therapy who already have removable among practice, you'd have 174 edentulous patients in an average practice. So learning this is an important part of your dental education, as you know. When we're talking with our patients, we need to have a couple pieces of information that we share with them to help their decision-making process and make sure that they're happy with the results that they get at the end. A lot of times when you talk to patients who are currently wearing removable prosthetics, their greatest pain point, if you will, is the lack of stability of the prosthetic. Oftentimes they can get good aesthetics and reasonable phonetics, but the instability with chewing and speaking can be frustrating. Now, when we do our job properly, the prosthetic should fit well. We can design the occlusal scheme so that we get even force to help keep it in place, but it's not the same, as you guys know, as a fixed restoration or natural teeth. So when we're talking with patients who, especially patients who are dentate, we need to talk about stability. So that way they know what we can deliver. I mean, I think I have a slide on this a little bit later, but it's a good point to mention under promise and over deliver. Another thing to keep in mind is as you're looking at patients, you know, I've seen some patients where there's just no possibility of getting a stable restoration. When we run into those situations, we need to talk to our patients and let them know, hey, for you, given this, you can show them what's going on. I don't think this prosthetic is going to be stable for you. So that way they know what they're getting themselves into. The other thing I think we need to talk to them about is hard and soft tissue loss. As you guys know, internally loaded bone tends to be retained and externally loaded bone tends to resorb. So when we talk to our patients about implant therapy and about removable therapy, we need to let them know that the longer they wear a removable, most statistically, they're going to have less bone and it'll be more time-consuming, expensive, potentially painful to get their implants. So, you know, I think this is also a good time where we can talk about removal, relines and maintenance of our removable prosthetics. So that way the patients help themselves the most that they can. You know, and I think there's a feeling sometimes, well, I know this patient isn't going to do implant therapy or whatever. Okay, that's fine. But if you think about how things can tend to go wrong in our relationship with our patients, a lot of times it's just because it wasn't clear from the outset how things could go. So if the patient chooses a therapy that'll be more, what am I trying to say? It'll work out better for them, great. If they choose something else, then there's no problems with expectations because we already have had that dialogue at the beginning. So we're going to talk about tooth and tissue supported removable prosthetics today. In your practice, you also have the option using RP4 or RP5 implant supported removable prosthetics, which help solve that stability problem. But those are complex enough to merit their own discussion. If I put them in, we just wouldn't be able to cover it today. So if your patients decide on a removable prosthetic, you'll be treating them with either partial denture or full denture, depending on the number of teeth remaining. For partial dentures, we have quite a few different material options available to us, and we'll talk about these different options at the end. And then we'll talk about our full denture options. So I was trying to figure out how to organize this, and I thought I'd organize it by clinical workflow. So we'll talk it through initial assessment and then treatment planning. Again, sorry about that. Patient expectation. So anyhow, just making sure that we understand what our patients want, and we can talk about if we can deliver that, what the costs and treatment necessary to deliver it, that sort of thing. Want to make sure we start getting our good records. So we'll need our surface and radiographic data, and so we can kind of think about what procedures are going to be necessary to prepare any remaining teeth. We'll probably want some PAs, a PANO, CBCT, periodontal assessment, iOS scans or models, and photographs, both of the teeth themselves and of the patient's smile. If you have a facial scanner, this is a good time to take a 3D scan of the patient's face. So you can, especially when you're doing any interdisciplinary planning, you can share that with your colleagues. If you have a CBCT scan, it'll help you if you're going to be doing, if you decide you will be doing some implant therapy. Obviously, you guys have a lot of training in the biologic dimensions of treating existing teeth, but we do want to think about the prosthetic implications of the teeth that we're saving. Once you've decided what teeth can be saved, you need to decide which teeth should be saved. Let's say you have a patient who's missing 7, 8, and 10 and wants to do a partial denture. If you choose to save number 9, it's going to have a few implications. You don't have as much freedom in selecting the shade that you want. Most of the time, you're going to see a slight transition line between the partial on both the mesial and distal sides of number 9. And in terms of setting up your gingival height, the gingival height of the other 3 teeth on the prosthetic is going to be determined by number 9. So in that situation, and again, in discussion with the patient, you may decide that you extract number 9 so that you get a much better result for the patient. So if you have a patient who has good posterior teeth, they may want to do a partial, and they may even want to use a precision attachment on there. Another thing to think about is, let's say you have a patient with some good cuspids, but they're in the wrong position. Potentially, you could do endodontic treatment and a root form locator. So if you have a patient with no residual ridge, you may want to look at tell them, I don't really feel comfortable moving ahead with just a denture for you because it's going to move around all the time. It's not going to do you any good. We need to get a couple implants in. A lot of offices like to have a good, better, best presentation for a patient. So in our 7, 8, and 10 scenario, maybe our good presentation is we extract 9 and we do a Clearframe partial on 7 through 10. Maybe our better presentation is 2 implants and a 4-unit bridge. And maybe my best presentation is crown on 9s, implants 7, 8, and 10, and immediate provisionalization. So it's not necessarily, you don't always have 3. 3 is kind of a good number, but it's nice because, again, that way you've given the patients the options that they need, and they make their decision. You provide them with the treatment, and helps a lot. So you have things like RPIs we'll talk about, attachments, or saving a key tooth, even with aggressive therapy, to make a better result. One of the things I love about dentistry, and I think you guys are already finding, is that there's always more to learn. As we continue to take advantage of the education opportunities that are in front of us, it gives us more tools in our toolbox to provide the best options for our patients. You're going to want to have ballpark prices ready for your patients when you're just discussing courses of treatment. One of the things I like about multidisciplinary study clubs is that it gives you an opportunity to develop strong relationships with a group of specialists ahead of time. And you can kind of talk about typical treatments that you have, kind of work together to get some fees. For whatever, I mean, I guess we understand this. A lot of times our patients, the thing they understand most about dentistry is the costs of it. And if we can't provide a solid, if they say, well, how much is it going to cost? And we can't give them a good assessment, it hurts their confidence in our ability to provide the treatment that they need. Financing, I think, is important. We want to make sure we have some good options. Again, for our patients, the financial side of this is really important, and making sure we can provide them with with good financing makes us seem like a better option for them. And then we want to make sure that when we do our case presentation, we don't not only present the clinical aspects of it and the financial aspects of it, but we want to make sure we talk about, to the best of our ability, what their experience is going to be like. And again, this is mostly about managing expectations. If we expect them to have an excellent result and it feels just like teeth, I think it's okay to say that. If we think that it's going to be very unstable, it's okay to say that. This is my under promise and over deliver side. I think this is really, really important. We want our patients, oftentimes, and you guys I'm sure have run into this, patient communication is a difference between a patient being satisfied with a result, with a clinically acceptable result, and unsatisfied with a clinically acceptable result. I'll stop beating that eventually, but I just think it's so important for us. Of course, we want to make sure that our patient's dental situation is stable before we make any removable prosthetics. We also want to minimize the number of patients. I mean the number of visits. Our patients love seeing us, but if we can work together with our specialty team and our dental laboratory to get as much as possible done each time we see them, they'll like that. So when we're making up our treatment plan, we want to make sure we're respecting their time. So we'll want to start out with extracting any teeth as early as possible and have a viable provisionalization plan, because we want the soft tissues and hard tissues stable before we make our final prosthetic. If we decide we're going to be doing some implant placement, we also want to get that done at the time of extractions so we can, so they'll be integrated and ready for treatment, and any surgical periodontal therapy. We'll probably want to do endodontic treatment and crown and bridge restorations next because of fabrication time. If you're using attachments affixed to your crowns and bridges, make sure you talk to your laboratory about whether you'll be seating those permanently before starting, say, a partial, or if we'll want to pick them up in the impression. Not all attachments have a reliable impression coping, and so this is really important. One thing about attachments is that we live, as you know, in a very mobile society, both for us as the clinical team and our patients. So having good documentation about what kinds of implants and attachments we're using and putting those in the chart and giving that information to our patients can really be a good service to them, especially long term. So our next step is we want to figure out our vertical dimension of occlusion. We do find removable patients with a functional habitual bite, but often these patients have lost vertical dimension and they may even have dysfunctional bites, just trying to get function with the limited number of teeth they have. So when we're doing our larger removable cases, we often have the opportunity to correct these deficiencies. So on the left-hand side, I have the traditional method, which is making marks and trying to find the vertical dimension of rest and then building VDO from that. But it seems like the instrument on the right, the Conmedier instrument, has kind of taken the full arch world by storm. It uses facial proportions between the corner of the eye and the corner of the mouth to establish VDO. And it seems like most practices that are doing a lot of full arch are using this all the time. The other thing that's nice about it is it gives you a measurement that you can use and record in the chart. So I think either method is great for finding VDO, but I'd say the one on the right is faster and easier to document numerically. So once we have the VDO, then we're ready to try to capture our CR. If we're opening the bite, especially most people would say that centric relation is the repeatable jaw position that we want to try to establish. If our person has teeth, a lot of times a leaf gauge can be a great way to do this. We'll add a stack of leaves like this in our left-hand picture until the person is open enough, and then we'll inject bite material while the person is gently holding that. And as long as the teeth are discluding, we'll have CR. When we're working with bite blocks, which is what we'll be doing most of the time, obviously with our denture cases, and even with a lot of our partials, it's a little bit different. We'll want to make sure that we trim the occlusal surface of the bite blocks so that the person is able to close or to achieve the vertical dimension that we want. And then when we, once we put some notches in our occlusal plane, we'll ask the patient to try to bite on their back teeth or where their back teeth would be to establish CR, then have them hold that position and inject bite material in between. Keep in mind when you're using your bite blocks, they're like the pre-try-in. If you shape up the buccal surface to show the buccal corridor and where the facial surface of the anterior teeth should be, and then you set your plane of occlusion in the right spot, incisal edge position, mark your midline, your high smile, you'll find that if you put a little extra time into this, your setups become less a exercise in moving teeth and more of a approval step. So a little bit of extra time invested there can make a big difference. So I would recommend trying to get any changes you want to make in tooth position and occlusion done in your provisional. The reason is the patient will be in that for a while, and I feel like it's kind of a try it before you buy it. Let the patient see what it looks like, feel what that bite looks like, see how functional it is. It gives us an opportunity to do a test drive when we're making some big changes. Sometimes we can't do that, but I think as much as possible, we want to have our patient experience final tooth position and bite early in the process. The earlier, the better. So at this point, you've created your treatment plan and you'll have presented it to the patient. And now you're like, okay, I'm getting going. What do I need to do? A lot of times we like to use custom trays for removable cases. And the reason is because it allows us to have a uniform depth of impression material and adequate support for border molding. You can look at the trays you have. If you have a tray that has good fit and borders, you can use them. There are some trays that are designed specifically for edentulous arches. So you kind of need to use your judgment in that. One of the things I like to talk about is every procedure is going to take X amount of time. If you're going to do a full denture, it's going to take, let's say, an hour and a half of clinical time total. And you can either spend more time, because my process I'm talking about here puts more time into the front end of it. Treatment planning, impression taking, records, stuff like that. But as we talked about, it makes the setup go a little bit faster, makes the final go quite a bit faster. So you find that you're spending less time at the end when it's harder to make changes. You can push through at the beginning of the process and try to go a little bit faster there, and that's fine, but you want to make sure that you're not just basically creating problems that'll make the end of the process more time consuming. I feel like investing time at the front end makes the clinical experience a lot better. When you're taking your partial impressions or your fixed impressions, your IOS, I think, is your best thing if you have one. If not, make sure you want to use polyvinyl siloxane or polyether to get a really nice, accurate impression. We want to make sure any of our extractions are done before we take master impressions, especially partials. Your laboratory has to decide what the path of insertion is, and we don't want teeth that are not going to exist dictating the path of insertion. Like we talked about, if you're going to be doing fixed restorations, crown and bridge, that sort of thing, you want to make sure that you have those done before you're starting on your removable. If you have facial scanning, that's great. You definitely want to take, like this photo, a nice smile photo to show tooth position. You know, not the prettiest teeth in the world, but it shows us where the plane of occlusion is and things like that. Last but not least, you've done some hard work on your bite. Make sure that you record the bite registration that you've developed so that way we can use that for all our final restorations. So, as you guys know, we want to cover as much stable tissue as possible. So you want to make sure you get to the borders of where the mobile tissue starts. In other words, on the maxilla, we need to get past the vibrating line, past the tuberosities. We need to make sure we get into the vestibule. And so that's really important. Things like the vibrating line are hard to pick up on the model. So if you mark it on your, on your impression, that really helps your laboratory. On the mandible, that becomes even more important. And things like we want to make sure we catch the whole buccal shelf so that way we have a nice stable surface for our mandibular dentures. The last thing you want to keep in mind is that you know more about anatomy than your laboratory does. And so sometimes your laboratories will be like, well, I'll just cover everything I can see. And they may not appreciate that, some of these tissues, we don't want to put a removable prosthetic on it because it's moving all the time and it's going to get sore spots and the like. So finding that way of helping your lab by giving them your clinical expertise makes a big difference. We want to make sure that when we're doing removable prosthetics, full dentures, or even large partials, that our impression will be well fit to the dynamic movements of the mouth through border molding. You can use an impression tray, of course, or you can use an existing denture for a full arch impression. We want to make sure that the tray covers the areas that must be captured. Like if you look at this lower denture, it didn't capture the retromolar pads. So the dentist used compound material here to extend those borders to support the impression material. So we'll want to go ahead and use our heavy body material on the borders and then have the person go through their border molding movements, do the same thing with their light body. And what we're trying to do is activate all the muscles around the prosthetic so that way this edge is shaped by those muscles. Because then we know the patient's less likely to have sore spots, the prosthetic's going to be more stable, they're going to have a better solution. So we'll send it to the lab will make a base plate and do a setup. And sometimes when we do our setups, we're like, it's just a setup, who cares? But we really want to focus on this point from two directions. One is that this is the first time that the person is really going to see what our proposed treatment looks like. So we want to make sure it looks good, that they're like, oh, wow, this is cool, feels good. We want to talk to them about the fit of it. We'll talk about some of the different partials. You can't try the clasping until the final appointment. So we want to talk to the patient about stability. And again, when we approach this, thinking about it like our patients do, stability is going to be one of their larger challenges. If we're doing a traditional workflow for our dentures, there'll be a little bit of blockout. So the base plates won't fit as snugly as the final restoration, but they'll be similar. And then we want to talk about, like, every once in a while, we'll talk about this with digital dentures. It's possible to get a printed try-in. And with those, you can actually send the person home with it and do a little bit of a test drive. It won't have pink on it, so it doesn't look as pretty and it's not as sturdy as the final denture, but it gives the person an opportunity to really try it out. So then we send it back to the lab, gets processed, and we're ready to deliver it. Our goal is that this is basically put it in and send them home. With some flexible partials, you will be trying the clasps for the first time, so that can be a little bit of adjustment. Our analog dentures will have a little more retention, and basically what we're doing at this point is we're confirming that everything we planned we were able to achieve. Keep in mind pressure spots under the prosthetic. You'll want to check that carefully. And if you see some areas that are going to be potential sore spots, bring your patients back soon. If you get the spot when it's ulcerated, you can make adjustments, but it's so painful that a lot of times it's difficult to see if you've done enough adjustment. So kind of bringing the patient back proactively in a couple of days can be a good way to avoid things getting out of hand. Last but not least, a lot of removable patients, or at least a fair amount, don't really have a solid relationship with a dental office. And one of the things that you can do with this treatment is, even if your patient chooses a less expensive option, a removable option, or something like that, when you do a good job for them, you're building your credibility and you become their partner of choice if they decide to do something else in the future. Again, if you've told them what the experience will be like, delivered a good experience, and they're finding it's exactly what you told them, then they're like, oh, well, maybe these other things that doctor talked to me about might make sense too. So there's that. So then we want to make sure that we set up a maintenance schedule appropriate to their hygienic situation. Sometimes these patients can just fall off the map. But again, as we talk to them about the importance of relines and fit of their prosthetics, setting up a maintenance appointment is really good. If you have resilient attachments, of course, those are going to need to be replaced from time to time, and we'll want to have a schedule with that. And again, you've talked to them about potential bone loss due to prosthetic instability. So tell them, okay, remember we talked about this, so we need to set up an appointment to keep this fitting well for you. So I'm going to do a very brief review of the components of a partial denture, because we'll start with partials and then we'll move into full dentures. So with a partial, we have our major connector, which provides stability for the prosthetic. It's rigid, it's designed to hold everything else in the correct spot. Our minor connectors connect different features of the partial, including indirect retainers, direct retainers, clasped arms, that sort of thing. And a lot of times with some creative use, our minor connectors can also be used as guide planes to help stabilize our partial. Direct retainers are clasps, the things that hold the partial in place. Indirect retainers are rests, like we'll talk about the different Kennedy classes briefly that help with stability. And then of course our denture base, that's the part our patients are interested in, that has our teeth and provides our fit to our edentulous regions. It turns out there are 65,000 possible combinations of teeth and edentulous spaces. So Dr. Kennedy back in the 20s, and then Dr. Applegate updated in the 50s, this method of kind of talking about different Kennedy classifications. I'm sure you've gone through this in school, so we'll just talk about the implications of it. A Kennedy class 1 with bilateral free ends is going to move because of tissue resilience. I mean, we want to minimize that as much as we can, but we'll talk about the RPI clasp design and how that helps adapt to that. Kennedy class 2s can be made more stable, but they also have an axis of rotation. So we'll usually need an indirect retainer to help avoid that movement. Kennedy class 3s, we can usually make these pretty stable. So when you're talking to the patient about what it will be like to wear the partial, you can kind of talk about, we're going to get this stable for you. Also, you can kind of design your major connector a lot of times to open up more of the palate on a maxillary case, which is nice. Kennedy class 4 cases are also usually stable. The main thing is dealing with the cosmetics of the clasping in the anterior region can be a little bit difficult. So when we're talking about our partial, we want to talk about our goals, and we kind of want to tier our goals because sometimes they work against each other a little. We want to make sure that our partial has retention. Again, removable patients, stability is their number one bugaboo. So we want to work as hard as we can at that. We want to make sure that our partial is not easily dislodged during chewing or speech. We want to make sure that it's also not so retentive they can't remove it for cleaning. This can be simple to achieve, but there can be aesthetic challenges witnessed here. We don't want our case to be unstable. So we need to decide what that means. Like we talked about in a Kennedy class 3, we may be able to get it very stable. But with our class 1, class 2 cases, we want to make sure we control the movement and minimize the movement. We want to make sure that support goes both ways, that when we design our tooth position, it supports our patient's face and speech and everything. And then we want to make sure that our partial has good support too. We're going to be putting a lot of load on the teeth with rests. So we want to make sure that those teeth can stand up to it. Sometimes we're going to be adding extra indirect retainers just to help avoid overloading individual teeth. If we have a retentive, stable, and supportive partial, it will be pretty comfortable for the patient. But this gets to the finish of it. It gets to the extension of it, gets to the design. We need to avoid large undercuts under our clasps and stuff to make sure that we're not creating big food traps that'll be uncomfortable. And then we want to make sure that especially our borders are not overextended to create sore spots. And then aesthetics. This can be one of our most difficult challenges with partial dentures. We got to make sure we hide the clasps as much as possible. Again, we want to talk with our patients about these things. If our stability and our aesthetics are fighting against each other, we'll both use our bag of tricks to select a material that will help with that, but we'll also talk to our patient, hey, we're going to have to make a decision. If I move this clasp forward, your partial will be much more stable, but you'll see it. Or if I move it backwards, your partial may be a little less stable, but it'll be more aesthetic for you. What would you like me to do? Good communication, so important. So we'll talk about a few different clasp designs briefly. Not all of these are available with every kind of partial. So we'll kind of talk about partials that can have rests and partials that cannot have rests. So if you want to do an Akers clasp, which is the most common, you're going to have a clasp. Usually the bracing arm is on the lingual and the active arm is on the buccal. And they're simple, they're versatile, they have nice bracing properties. They do have a lot of metal display, so they tend to be more popular in the posterior than in the anterior. A double embrasure clasp like this, usually only used on molars. These have a tremendous amount of retention. They're very stable. A lot of times when you have a Kennedy clasp 2, let's say your dentulous space is on the lower left, you might put this clasp over on the lower right just to tap down that whole posterior. Because a lot of times this, an indirect retainer, and maybe an RPI on the edentulous side's enough to get the case quite stable. Bar clasps. Bar clasps originate in the grid work of the partial denture and approach from the gingival direction. If the undercut of the tooth is low enough, this type of clasp can be much more aesthetic in the anterior region. Usually the clasp is named by what it looks like. So, you see the T, L, C, whatever. We'll talk about the I-bar clasp in a minute, the RPI, because it's a little bit different design. We need to avoid these in areas where there's a large undercut under the tooth, perhaps when the tooth is angled labially, because there'll be a big gap that causes a food trap. And also we need a nice deep vestibule to give us room for our clasp to emerge. RPI clasps. RPI stands for rest, plane, and I-bar. With an RPI, it always has a mesial rest and a distal guide plane, and it uses an I-bar for a retentive arm. Now, a lot of times people look at this, and me too, I used to think of this, oh, it's primarily for aesthetics. But what this is primarily for is that when we're dealing with a Kennedy class 1 or class 2, a perfectly fitting partial is going to have a little bit of movement, because when the patient bites on it, as you know, it'll displace the tissue. So we got to figure out a way to deal with that. If we do I don't know what you'd even call this, an RPI design with a distal rest, this is not good, because this force creates a fulcrum movement that's moving the anterior portion of my partial and also my clasp. So it's going to be very unstable. On the other hand, the mesial rest allows this to move slightly with having much less effect on the rest of the partial. So this is really your go-to, if at all possible, on your class 1 and class 2 cases. Obviously, you got to watch out for the undercut and the vestibule. This may be a situation where you would choose to do a crown to get the right amount of rest, guide plane, and undercut, so that way you could deliver an RPI and get a better result for your patient. So we're going to go ahead and talk about different tissue options or different options for partial material, but we want to talk about whether a partial is tissue supported or tooth supported. I feel like those are really the two big categories that these fall into. A lot of the modern flexible materials are not strong enough to make rests, so they're going to be entirely borne by the soft tissue. To reiterate what we talked about before, externally loaded bone resorbs while internally loaded bone is retained. So when we do a mucostatic partial, we do run the risk of having accelerated hard and soft tissue loss. And we want to kind of look at the case. When we have like a very large class 1 case with a large dentures area, we may not want to do a flexible partial, or at least an entirely flexible partial, because we're putting that much more load in that area. The other thing to keep in mind is that most of the flexible materials, the whole thing is flexible. So like the saddle is the major connector is flexible. So there's ways to work around that, but we want to kind of keep that in mind as well. So we'll start out by talking about a chrome cobalt metal frame partial. So these have been in use since the late 20s. There have been some recent EU regulations limiting the use of cobalt-based alloys. A meta study in 2022 of 21 in vitro and in vivo studies, studies from 95 to 02 showed that while it's not quite as biocompatible as titanium, it's much more compatible than nickel. Also, the results show no cytotoxicity to human cells during in vitro testing. One of the things to keep in mind about metal partials is even though they've been around for a long time, they've been around for a good reason. They're strong, so we can make a relatively thin framework. The framework, the metal, like any metal, is ductile. So by making the clasp appropriately thin at the tips, they can flex a little bit. The metal and the acrylic can be repaired on these. So if you need to add a tooth or something breaks, the patient can repair it as opposed to buying a new restoration. Also, metal partials can be made with rests, which gives you the full range of clasp options. It gives you tooth support, so you can minimize the force on the saddles. You can do kind of creative things with it. Let's say a person has 2 or 3 teeth left and you want to open the bite. You can make a partial with metal occlusions on those teeth to open the bite. So they really give you a lot of different options. Although the metal clasps are not as pretty, and there are a lot of patients that just don't want metal today. So we do have options for those patients, but I would say don't overlook your metal frame partial. There's a reason it's been around for almost 100 years, is because it's a versatile and reliable option. All acrylic partial. So these seem to have like a million names. You'll hear treatment partial, temporary partial, flipper. This is a partial that's made entirely from denture or acrylic with no frame. They're usually the most economic, and they're usually not intended for long-term use. You'll sometimes see wire clasps, as you see in this, embedded in the acrylic. Most of the time, the reciprocation, the bracing, is the body of the flipper itself. Because they move around a lot, they're going to exacerbate tissue loss, which is problematic, and they're going to be more prone to breakage. Because they're all acrylic, they could be 3D printed. I think most of the time they're still being made by traditional either cold cure or heat cure methods. Flexible partials, I say they're newer in the market. Valplast has been around since the 60s, so they're newer than metal, but not a brand new thing. The thing you want to keep in mind with this is they're more translucent as well. They're not only pink, but when you hold them up to the light, you can kind of see through them like you see in the palette here. So they do kind of tend to disappear, and they, but the whole thing is flexible. So the teeth are rigid, but everything else in this prosthetic can move a little bit. So this case probably is not a great one for a flexible, because when the person bites on this saddle will flex a little bit. They tend to be thinner, and they often have nice adaptation. So patients find these quite comfortable. One thing to keep in mind is that the height of contour on the supportive teeth is critical, because for this to look nice, the clasp needs to engage the tooth very close to the gingiva. There's two materials that are most prevalent for this. Valplast is a nylon material. It's essentially indestructible, but it's difficult to adjust chairside because it can kind of gum up your burrs, and it's not easy to repair because nothing chemically bonds to the nylon. Patients need to be cautious with alcohol or bleach-based denture cleaners that they don't degrade these. Duraflex is a newer polypropylene-based material. It's also very sturdy. It's a little easier to adjust chairside, and you can repair it. So one of the things I would say about flexible partials is just like each of you have your preferred materials that work best in your hands, you'll find with your laboratories that they have materials on both the fixed and removable side that work best for them. So when you're working with your laboratory, it's nice to have a conversation and say, hey, I can see there are advantages to Valplast and Duraflex. What works best at your laboratory? And when you give your lab the ability to use the material they get the best results with, you'll often find that then it gives you the best results in the clinical situations you're addressing. Combination partials. So you kind of look at these and you say, wow, sure would be nice to have the rigidity of metal on the lingual or palatal side with the nice clasp of a flexible partial. It is possible to do this. It's also a great option for patients that might have acrylic allergies because the flexible materials aren't acrylic. So keep that in mind. Clearframe is the last material we want to talk about. There's a lot of advanced polymers out there on the market. Yeah, I mean, you'll hear about PEAK, PEEK, different materials like that. Seems like this is the one that's kind of ready for prime time. It is clear. I mean, it's nearly as clear as a window pane, and you can put rests on it, so you can do kind of a metal partial type design. The one thing you want to keep in mind with these materials is that the what am I trying to say? They'll have to be a little bit thicker than a metal partial. And the framework on these cannot be repaired. The saddles are traditional processed acrylic, so you can reline it, replace teeth, that sort of thing. So current denture workflow was perfected in the 50s, and it can work seamlessly. Every once in a while, we get finished in 5 appointments. But a lot of times you can get extra appointments, and people get frustrated, especially in private practice, just because at current reimbursements and with the number of appointments, it can be difficult. Again, communication is so important. We need to talk about potential stability. We need to talk about sore spots and encourage our patients to let us know early so we can visualize the site better and make adjustments. We want to make sure that we talk about the stability of the case and give ourselves good predictability. Digital dentures are, I'd say, fairly new, the last couple of years, something like that. One of the challenges with traditional acrylics is that they shrink during curing 8%. There have been a variety of different methods like injection, post-dams, compensate for the shrinkage. But if we think about denture retention, we haven't talked about suction, but what it really is fit. The saliva seals the small gap between the denture and the tissue, allowing it to stay in. So when you look at a printed CAD/CAM on the right here, as opposed to a pack and press, big thanks to Dr. Scherer on this for his study, we can see that you tend to get a better fit with a printed, which is really important. Some of the newer materials, when printed dentures first came out, they had a hard time matching the strength of injected acrylic, but some of the newer materials, such as the Lucitone digital print, has a flexural strength of 200 newtons, way beyond the ISO standard, so it's going to be less likely to break. And one thing to keep in mind is that you can save the denture file. You can tell your lab, you know what, I want to save this for my patient. And so can you give me the file and let me know what materials were used, that sort of thing. You can document it. If the prosthetic gets broken, or if it gets lost, or if the dog eats it, whatever, you can actually remake it. Because sometimes we've worked hard on a denture and it's all good and you're so excited on an analog, and then if the patient loses it, you get to start all over again. One other thing I found in talking to dentists about what they like about digital is that the workflow doesn't have as many ways it can go awry. So you find a little more continuity. I realize I gotta kind of move along here. So there's a bunch of ways you can work with digital dentures. Just so you know, you can use your traditional analog impressions and then work with your laboratory to do a digital denture. Of course, you can do digital records. Edentulous scans can be done with some scanners, but what we find is that it's difficult to do the border molding digital. So the reference denture where you reline an existing denture, 80% of patients have a denture, tell them kind of, I don't care how much you dislike it, I just need it to get good records for you, can be the best way, meaning you reline the denture, you scan it, you scan the reline denture as your master impression. So with facial scanning, which is kind of a separate thing, there is a way to do a reference denture scan and a facial scan and get to a final in 2 points. One of the things that's cool about digital dentures is this printed try-in. It's plastic. It fits the same as the final, so you and the patient can evaluate the fit. You can shorten any borders. See, you need to add a little bit. You can mark on it. You could score a new midline. You could shorten things. You can mark on it with a Sharpie. You can take the case home for a test drive. So again, talk with your laboratory about the digital workflows that are available. But if you want to do digital work dentures, this can be a good advantage for you. Again, to reiterate what I said at the beginning, advances in implantology and biomaterials give us the ability to give almost everybody an implant-supported restoration. But you're still going to see lots of patients that do not or cannot choose this option. So we want to make sure that in our toolbox as clinicians, we have the best removable prosthetic results available. You can see that I beat on the communication skills thing. I think that communicating with your patient at the beginning of the process, at the middle, and then makes it much more pleasant at the end, really creates a better environment for you to work in and creates a greater patient satisfaction. So I think that's really important. Digital workflows have revolutionized fixed, and right now I'd say we're in the process of them doing the same for removable. So I think you'll see throughout your career, digital is going to really change what our options are as we're working with removables. So make sure you're keeping an eye on that. That's all I have today. Thank you very much for your time. I really enjoyed doing this. Have a good day.